Roy Lilley is with us. He's a former NHS Trust Chair. Roy, is this a big problem or not really?
Well, it is for the individuals who are ringing, 999 and they want help. But it's increasingly happening, Peter. I mean, as you say, there are 26 million total episodes of care in A&E. 25 million of them are brought in by ambulance. So that leaves 1 million of us that are walking wounded that kind of turn up and get ourselves to hospital anyway. But of course, what is happening now, the calls, I think the public don't always understand, the calls are categorised. So category 1 is life-threatening, you've stopped breathing or there's blood all over the place. Category 2, which I've always argued with, category 2 is heart attack and stroke. And epileptic fits and things like that. I've always thought they should be treated with a greater degree of urgency.
And certainly with things like stroke, we know that there isn't there that government plan fast. You got to go as quickly as you can because minutes matter.
Yeah, antithrombolytics, it's a very important part of how you treat people. So I've always argued that. And the other is when we hear stories of your granny lying on the floor with a suspect broken neck of femur and she's on the floor for hours and hours and hours, that's because it's a category 2 call. And what we've seen, I mean, there was even a story last year where the neighbours were so worried about this lady that they managed to slide her onto an ironing board, tie her on and take her to hospital in the back of a van on an ironing board. I mean, this is not really what you want, but I can understand absolutely why people do it. The ambulance service are now saying, well, in some circumstances, it might be safe to do it. You've had a heart attack and maybe you're through the worst and your wife can drive you in the car or vice versa or what have you. That's what they're saying. I mean, it actually, when people turn up with these emergencies in their own cars and what have you and dump their cars outside hospital and rush in and say, I've got somebody in my car that's had a heart attack, it causes a real big problem in A&E because, the staff then have got to come out, rescue somebody from the car, take them in. I mean, it just complicates it. But I absolutely understand why it's happening, and I think we're going to see more of it because we've got about four ambulances per 100,000 population here in Germany, France, and whatever. It's 7, 8, 9. We don't have the ambulances. We don't have the capacity. We know we're facing a really bad winter. We've got novovirus. We've got the rumbling of COVID still coming in, the flu, and so people are going to want to get to be taken to hospital. So in a bad winter, when the ambulances are tied up because they can't discharge their passengers because A&E is chock-a-block, because the wards are chock-a-block, this is the start, I think, of a slippery slope. We're going to see more of this.
It is fascinating what is happening in the NHS, and actually Wes Streeting, the Health Secretary, has announced a plan now for a mass expansion of GP services to save the NHS. I mean, it's a nice idea to say, let's just have lots more GPs, that will help. I mean, it would, wouldn't it, if you have loads more GPs? That's definitely going to help. But is it practical? Is this a plan that actually is going to work and is going to save the NHS?
Well, look, I can tell you, I mean, there'll be senior people in the NHS with their head in their hands this morning because it took 4 years to get the last workforce plan through the Treasury. So we've got to start messing with the Treasury again. I imagine the Treasury will say, listen, you've got your allocation. If you want to change the emphasis on who you train, you want to train consultants, or do you want to train doctors, GP doctors, then, you make that call. It's up to you. Here's the thing, though, Peter, this is all part of Streeting's announced intention to move more care out of hospital. Well, is it to move care out of hospital, in which case then you will need what? You'll need diagnostics, you'll need imaging, all of that, really. And to get that into primary care, where half of the premises are not fit for practice now, it's going to require a huge investment. Or is the idea to stop people getting sick in the first place? And if you look at what's happening right now, the frequent flyers, as we call them in the NHS, the big users of A&E are elderly people and children under 5. Now, if you look at elderly people and you want to stop them going into hospital, you've got to have social care and you've got to have really good district nurse services, as we used to call them. They're now community nurse services. We just simply don't have the nurses to do it. I mean, if I was doing this, I'd say, look, let's have a nurse-led primary care. Let's recruit nurses and train nurses. It's cheaper and it's quicker. And when it comes to looking after elderly, that's what we want. If it's looking after kids, it's health visitors, and we don't have enough of those either. So it's not enough to say we want more GPs. You know, everybody's going to say, yeah, let's have more GPs. But what exactly are we trying to do with the NHS? That's the most important thing, and I think that's muddled. I think to do this kind of foghorn policy through the Sunday newspapers, it's really not helpful. You do have to sit down and say, what are we trying to achieve? I mean, already there are 3,000 GPs without a job because we can't afford, the NHS can't afford to employ them. There's a row.
3,000 GPs, trained GPs sitting there not working as GPs.
They can't get a job. And there's a row going on over something called physicians associates, which are people with a degree, not necessarily a medical degree, who do a conversion course and they come in and they're sort of supposed to be doctors' assistants. And there's a row going on with the BMA, as you might imagine. They're saying, we don't want assistants, we want the real thing. And we do. But the issue is this, what do we want them to do? And then if you're going to have more GPs, well, there are about 6,500 GP practices. Only 1,300 of them are what we call training practices. They've got the facility to train younger doctors to become GPs, and it's a long old haul as well. So that would have to be looked at, and it's not cheap to convert somebody who's a young doctor into a GP. GPs are highly skilled. They're not rated. They're not consultants. And they say, consultants are the top gods in the NHS. No, the GPs do the really difficult job of diagnosing very difficult things and picking up serious things that are wrong and getting people off to see consultants. It's a really tricky job. They're specialist generalists, and it takes time.
I have a really excellent NHS GP, it must be said. I just want to ask your thoughts on what one listener has sent me in here. This listener says, let's nail this ambulance story. Ambulances are stacked up at hospital emergency departments awaiting admissions for patients, so this reduces the number available to respond. My elderly mother had several strokes. Once an ambulance brought her to the emergency department, twice she was driven there by a neighbour, another time by me. Getting her there ASAP was vital. We talked about that, of course, a minute ago. If it's a suspected broken hip or neck, it's best to wait for an ambulance crew, of course, but we're in the real world of severe NHS pressure, and we, the public, need to do what we can. People standing looking at someone with a suspected heart attack or a stroke are not doing all they can to get the medical assistance. That makes no sense. Many vulnerable people have no one to drive them. Ambulances should be freed up to attend to those people. And for those who phone ambulances for minor issues, and these are often repeat offenders, they should be ashamed. Roy, your reaction to that?
Well, whoever this guy is, I'm with him. I mean, he's absolutely right. I mean, the British public aren't stupid. They've got a lot of common sense, and people are now being conveyed in the language of the NHS, the management language, conveyed to hospital, taken to hospital in neighbours' cars and things like that. And why not? It makes a lot of sense, and I think that's right. And of course, as far as the more trivial cases are concerned, well, I spoke a moment or two ago about the categorisation of calls. There are 4 categorisations, and the trivial ones are down 3 and 4, and they don't see an ambulance for a long time. People get fed up with that. But so, I mean, the NHS is doing what it can do with the capacity that it's got. All of this is about capacity. If you look across Europe or the OECD countries that have got similar sort of developed healthcare systems, we have fewer doctors, fewer nurses, fewer scanners, fewer diagnostics, fewer beds. The whole capacity of the system really went to pot in the 10 years after the World Banking crisis, when the NHS had 2% funding year on year, and it just didn't buy enough, innovate enough. And really, the chickens are coming home to roost now. And of course, what is going to happen now this winter, I can tell you, we're going to get a lot of what we call medical patients coming in. These are respiratory patients, often elderly people coming in. They need a bit of a sort out on the wards. They come in. The medical beds will be full. The NHS has 2 sorts of beds, medical beds and surgical beds. The medical beds get full, then they start transferring patients from medical beds into surgical beds, and surgical beds are where we go if we need a new hip operation or waiting list, new knee and what have you. And so we start displacing the surgical beds, and eventually it comes down to ringing up your granny and say, you were coming in on Tuesday for a hip. We can't do it because the beds are full. That's what happens. The medical patients spread into the surgical patients. The knock-on effect then is the waiting lists start to go up. And I can see it coming.